to allow a few more people to join us before we kick things off here. So just hang on for a minute. Thank you, everyone, for joining the CHCF Innovation Webinar. My name is Jared Teo, and I'm a Senior Program Officer in the Innovation Fund here at the California Healthcare Foundation. So one of the many goals of our team and CHCF is to improve access and help reduce the cost of healthcare. And we do this by supporting technology vendors and entrepreneurs who are improving access to care, lowering the cost of care, and or improving the efficiency of community health centers. So our work is largely informed by the feedback we get from clinicians, health IT staff, providers, and patients, and your feedback on an ongoing basis is critical to ensuring that we are supporting the right type of opportunities. And today is one sort of way and avenue that we look to seek your feedback. And because the goal of today's webinar is really to showcase a very exciting solution that automates routine and repeatable tasks to make providers more efficient. And in this case, specifically around a solution called Swoop, which is a software that automates the prescription refill process. Before I hand over the controls to Jonathan at HealthFinch, I wanted to go over a few housekeeping items. One, this presentation will be recorded and posted online, so those that couldn't join us today can access it and view it later. The lines will be muted during the presentation, but please feel free to type in questions in the chat box. And be sure to click on the chat button and select send to all participants in order to post questions. And I'll keep close track of that and raise those questions. And also, if you have any question, any technical issues, please email Canel. Her email address is displayed right here on the screen. So once again, thanks for attending, viewing the presentation and the following product demo, and being engaged with us. And with that, I am going to hand over the presentation over to you, Jonathan.
Excellent. Thank you very much, Jared.
You're welcome.
All right, let me just get it up here real quick. All right, so we should be all set. So thank you again, Jared, for giving me the opportunity to talk with you all today. The title of our presentation today is Improving the Efficiency and Quality of Care Through Automation. My name is Jonathan Barron. I'm the co-founder and CEO of HealthFinch. And today, as Jared mentioned, we're going to be spending a lot of time focused on the routine, repeatable work that overwhelms physicians and their staff. And as we talk about that, I'm sure that I don't have to elaborate to everyone on the phone the consequences of the burden of this routine, repeatable tasks on physicians and their staff today. So we look at different statistics, including the ones listed here on the screen. So 1/2 of physicians have reported being burnt out. Our belief is that, again, that a number of that is attributed to the amount of routine tasks that are being placed on them today. If you look at the average turnover rate on a per physician basis is 6.6%, which equates to an average cost of anywhere between $500,000 to $1 million to replace that particular individual. The average physician will spend between 2 to 4 hours per day on EMR documentation, and will see around 100 different tasks in their in-basket or in-box today, including refill requests, diagnostics, consults, and other messages. And so I don't have to, or I want to take first a step back and understand these challenges in the context of what's going on today, particularly as we think about a health system that is largely reactive and inefficient. And so I want to play this through the patient's lens. So let's imagine first that we have a patient that is a 40-year-old female. She has asthma, depression, high blood pressure, hyperlipidemia, and atrial fibrillation. This all presents with it, of course, an annual exam that needs to get performed on a regular basis, where a patient's going to have multiple diagnostic orders that are going to be placed. They're going to present with a 10-pound weight gain and be complaining of chest pains, as well as there's As well, they're going to need to get a PAP performed, vaccines, regular meds checked, and all sorts of labs that are going to need to get performed, as well as other refills that are going to need to get given. And if you think about the circle here on the screen as a representation of this patient's journey through the healthcare system, it's a circle because the patient is going to come back on an annual basis to be seen for their particular condition. But you think about all the things that today happen largely reactively in the process. So all of these things, so whether they're getting PFTs, their INRs performed, an EKG, a mammo, all of these things are individual workflows that get performed largely on a one-off basis. And so this means that all of these today, again, these are workflows that largely result in results being sent to the provider inbox. The provider is then responsible for making the decisions. The nurses then needs to be notified of how those decisions need to be addressed. The nurse creates the appropriate orders. The patient's notified to retest. And again, all of these steps get repeated over and over again. And this results in between 10 to 15 in-basket tasks for medical staff that they need to address, again, on a one-off basis. So you think about all of these coming in throughout the course of the year. So the INR needs to get redrawn. Meds need to get refilled. INR needs to get performed again. Asthma needs to be rechecked. And then furthermore, all of these happen across the patient life cycle. So we largely think this results in one of the big problems that we have today, which is that the health system today is largely reactive. And instead, our goal as an organization is to turn this as much as possible into proactive management. And so our mission as a company, and as we like to think about it, is to take those routine tasks that flood the physician's inbox as well as their day, and use technology to automate what we can automate, delegate what we can delegate, and simplify the rest. And the first application that I'm going to talk about today is an application focused around prescription refill requests. And so I'm sure many of you have seen this particular workflow and understand its impact on your organization. So if physicians are handling this work today, the average physician will spend about 30 minutes per day handling prescription refill requests. And if your staff are handling it for the physician, you're going to need something on average of 1 FTE for every 1 FTE to manage 20 physicians worth of prescription refill requests today. And again, our goal is or what we've built is an application that sits on top of your electronic medical record to automate this process as much as possible and make it as efficient as possible for physicians and their staff. And so the way that this application works is threefold. So all prescription refill requests are first entered into the EMR. And they can get into the EMR via a number of different mechanisms. So whether that's faxes being manually entered, patient portal requests that have come in directly from the patient, or SureScripts requests that come in electronically. Then all of these applications, rather than directly going to the physician, largely the physician or the staff in basket, they first get intercepted by our application, which processes and routes these refill requests to the most appropriate team member. And the way that that application works is based upon standing orders that we work with your organization to create. And so we have built up a tremendous amount of content around refill requests or around refill protocols that is evidence-based where possible. And to date, we have over 1,500 protocols that we then deliver and work with your organization to establish on a moving forward basis that can allow for the delegation of refill requests from physicians to staff. And so when those requests come in and Swoop intercepts them, our application automatically applies that protocol. So it automatically searches through the electronic medical record to pull out all the pieces of information that are going to be needed for that particular request to be processed. We interpret that patient data. We identify things like care gaps, so whenever patients might be due for office visits or lab checks. And then ultimately, we tee up that refill order within the electronic medical record itself. So our goal is to build a technology that completely integrates into the EMR workflow. So there's no new application that needs to be learned. and it fits into the workflow that's been established today. And so all of this appears within the EMR inbox today as a fully populated request. And I'm going to show you in a little bit how this plays out from the demo side. And so to talk about the demo side, well, first I want to pause and ask if there are any questions in general about the refill process, or if anyone has any comments around how the refill process today is currently managed. And Jared, will you let me know if there's any questions?
Yes, will do. Thanks. Hey, Jonathan, there's nothing right now. I'll let you know if something comes up.
Okay, excellent. So then moving on to the demo phase. So again, the goal of the application is to make the physicians and their staff as efficient as possible in processing refill requests. And I'm going to show you a little bit after this demo a case study around how we've been able to substantially reduce the amount of work that's associated with this process. But first getting into the demo piece. So what I'm showing you here is a mock-up that hopefully resembles the EMR that you currently work in today, so to a certain extent. So all refill requests, no matter the EMR, come into the inbox, and that's where these refill requests are received. And so this, imagine, is the EMR that you work on today. This most closely resembles an Epic system for any folks that are using an Epic environment that are on the phone right now. But the goal of the application is, again, to intercept these requests as they come in to the inbox. And so you see on the far or in the middle of the screen, the first thing that we've done is apply a refill status to the protocols. So where you see in protocol, out of protocol, medication error, and duplicate request. So in protocol means that the protocol has been met and everything is good to go. Out of protocol means something about the protocol has been violated or no longer meets the protocol. A medication error means that something is going on with the patient's medication list that needs to be addressed for that particular request. And then ultimately there's a duplicate request, which I'm sure many of you have seen from the pharmacies when they send multiple refills or multiple requests for the same medication that will help you to identify. So starting at the very top of those. So again, what we do, this is completely contained within the electronic medical record itself. So we don't have any separate interface that we use. Our interface is the electronic medical record system itself. And so for this particular refill request for Lipitor, the patient was requested a 20 milligram oral tablet. So that was all standard information that had come in this case through SureScripts. But then you see under the notes section how this process was applied with Swoop in action. So per that patient's protocol, which was the anti-lipid agent protocol, this patient received a should receive 2 months worth of medication. So all of this was applied based upon, again, the standing order that we worked with your organization before going live to establish and create. And then based upon the patient data that was associated with it, this medication needed to be, or is allowed to be refilled for 2 months. And you can see underneath the protocol section, the rationale, where it lists a brief description. So this refill is going to last until the patient's next scheduled appointment. Underneath there was 3 pieces of data that were pulled out of the EMR to come to that decision. So the first was the last visit, the next was the next scheduled visit, and the third was the patient's LDL. And because all of those values were normal and in range, meaning they had been performed on a regular basis, this patient was recommended to receive a 2-month refill. And so what this what Swoop did is, again, it sent this to the right individual. So it sent this task to the refill staff rather than to the physician. Then this particular request applied the protocol, the result of which was that the medication was to be refilled for 2 months. And then finally, this order was fully teed up within the EMR to reflect that the patient needed 2 months worth of medication. And so that turned into a quantity of 30 pills and 1 refill, which equates to 2 months worth of meds in this particular case. And so the goal, again, of the application was to do all this automatically in the background for the staff member. So now this task, which would have taken between 5 to 7 minutes before, is something that can be completed in 30 seconds or less. So the application does not automatically send these requests back to the pharmacy, but instead fully tees up the task to allow a staff member to come in and handle the task. So I will again pause right there just to make sure there are no questions on this first example, and then I'll move into some other ones.
Yeah, if anyone has any questions, please type them into the chat box, and I can go ahead and raise them. The lines are muted now, but we will unmute them at the very end for just sort of open Q&A. So Jonathan, nothing yet, so go ahead.
Okay. So that was an example, what we just talked about, of an in-protocol request, which, again, it means that all the criteria were met and the request is going to be good to go. Now, in this particular request, you see an out-of-protocol. So what that means is that something about the protocol has been violated. And in this particular case, the patient has an abnormal hemoglobin A1C. And so this is just one example of what could be many potential areas where the protocol could fail. And so what we do when we're working with our organizations is establish what is going to be the standard workflow for cases like this, such as around abnormal lab results. And so what would likely happen here is that we would put in place either process where this would automatically go to the physician, so the physician would need to address this, or another common workflow might be that the staff member is going to look at the refill request, at the lab results, make sure that it was addressed by the physician, either via an office visit or via some sort of communication to the patient. And if it was good to go, or if the physician was aware of the abnormal results, then this medication could go ahead and be refilled and taken off of the physician's plate. So that's a second example. And then one of the, so jumping into a new area that we focus on, which is called care gap batching. And so one of the really cool things that we do when a refill request comes in, Swoop automatically runs all of the patient's active medications through protocol. And so it's not just the medication that was just received, but all of the other medications also get run through protocol. And so through this process, we're able to catch over 25% of diagnostics that would have otherwise been missed in the process. And so to give you an idea, again, visually of how this works, so a refill request for Lipitor is received. Then the second step is all of the patient's other active medications are run through protocol. So the Lipitor was requested, and there may have been an LDL that was overdue, but the patient is also due for our carbamazepine level, and that's also overdue. And so then what we do, or what Swoop does, is it automatically sends a scheduling message indicating that the LDL is due and the carbamazepine is due, and the orders are fully pended and teed up within the system. And so this allows, again, to catch 25% of care gaps that would have previously been missed through automating this previously manual process. And so to give you, again, an example of how this might look in the EMR, particularly, again, this looks like more similar to an Epic system, but the patient is on Tegretol, and so we would then send a scheduling message indicating that the patient's due for an LDL as well as a carbamazepine level. And so this allows us to catch those previously missed checks. Then another cool feature of the application is that the duplicate checking. And so in this particular case, there was a refill request for Lipitor, But previously, there was already a refill request for Lipitor within the system. And so what the application did is it automatically detected that the medication, this particular refill request, was a duplicate request, and it auto-denied it back to the pharmacy, indicating that the patient was, when the patient last ordered or last received the medication, the quantity and the number of refills that they received at that time. So we completely take all of those duplicates, which regularly amount to usually 9 to 10% of all refill requests, off of everyone's plate. And then, so this piece particularly focuses on what I mentioned before, which is that standard standard workflow that we work to put in place. So one of the biggest opportunities for using the application is to, at the time of introducing the application, to really standardize your workflows. Because one of the biggest things that we've seen is that through the standardization of workflows, you can then put in place technology that's really able to supercharge that process. And so one of the first things that we do when we engage with a new organization is bring all the key stakeholders to the table, so physicians and nurses, whoever is going to be handling the refill request, and make sure that everyone's on the same page for what are going to be those standard workflows. And so in this particular case, you see this was a medication error, which you see on the left. But in this case, the refill was requested for a previously discontinued medication. And this is one of the most important safety checks that we have within the system, because we know that there are many times that medications get discontinued, but that never gets communicated to the pharmacy. And then the pharmacy is on these auto refill systems where they'll request these patients' meds even though the patient didn't actually request them. And so what you end up with is refill requests for previously discontinued medications. And if those aren't addressed appropriately, obviously that represents a potential safety and quality issue for the organization. And so in this particular case, again, we work to identify and put in place those standard protocols. So to give you an example of this, so the nurse or a pharmacy tech could be handling these particular requests, and they get notified to review the encounter. And so then they're going to look in the patient's chart and ask the question, well, was this patient or was this medication truly discontinued? Could this have been an error by whoever marked it as discontinued? And then if it's clear that the medication was truly discontinued, they would then contact the patient to ask them if they had actually requested that medication or not, or if they knew that the medication was previously discontinued. And if the patient indicated that they were still receiving the meds, then the request would get forwarded to the physician. Or if it was truly unclear whether the medication was discontinued at all, that request then gets sent to the provider for an ultimate review and decision. And so again, to reiterate the point here, the goal of using the application is as much as possible to standardize these previously unstandard workflows so that we can then use the technology to make everyone more efficient in the process. And so I'll pause there and see if there are any other questions right now as I have gone through that first phase.
Jonathan, could you maybe spend a few minutes talking about, we talk a lot about the workflow here. Question a little bit about the technical integration, right, and which EMRs and that you're currently integrated with and that you can work with, and a little bit more about that part of the sort of the workflow piece.
Yeah, absolutely. So I mentioned that we perform this integration that's tightly integrated into the workflow. And so our focus today as a company is around 2 EMR vendors, Epic and Allscripts, so Allscripts Enterprise. And the reason for that is because when we're building out a product, we need to make sure that it, again, tightly integrates into this workflow process. And to do that, it's very challenging to integrate into many EMR vendors at once. So our focus today is largely around Epic and Allscripts, and I'm happy to answer any questions in particular from any organizations that would have any additional questions around the technical integration pieces of either of those two EMRs.
And also, can you maybe spend a few minutes on talking about the sort of the type of organization that can benefit from a type and size and that can benefit from something like Swoop?
Yeah, so we have seen organizations really of many different sizes that utilize the application. And really, it can come in different forms. So we've worked with organizations that today send all of their refill requests directly to the physician. So these organizations, the goal of implementing Swoop is to offload physician work to free up time. So whether that means to see more patients or in some cases just to give the physician some extra breathing room in terms of their current workload. Or it can be organizations that are currently offloading this work to staff in some form. And one of those two forms is either in a centralized workflow. And so what these organizations have done is they've taken the work and shifted it to another member of the team, so it might be an RN or a pharmacy tech. And in that case, centralized the team, meaning they've brought together people that are focused and dedicated around just handling prescription refill requests. And those organizations we've seen have been able to make tremendous efficiency gains utilizing our system because, again, working towards that standard workflow and then using the technology on top of it. And then the third really high-level workflow that we see is around is a delegated model, but is decentralized in nature. And so what that means is that the organization has delegated this to another member of the team, but those folks are then working usually in the individual clinic locations. So these folks are then like there might be a dedicated individual at each clinic, or sometimes it's a shared responsibility across the staff. But we've worked across all three of those models. Usually the first one is around physician time savings, and the latter two are around staff efficiency and or quality gains.
All right, thanks, Jonathan.
Thank you. Excellent. So then moving on. So as I had mentioned, so what we had first looked at is the refill staff in basket. So these are the folks that are handling the actual refill requests. And again, I want to reiterate, the goal is to take those completely off of the physician's plate, so they're able to completely sign off on their requests without needing the physician to be involved. But then the next group of individuals that we work with are the scheduling staff. And so I already touched on this a little bit, but to give you another example of this, so this is a refill request that would have gone to the refill staff, and this is an in-protocol request. But the common workflow is that a refill is received, and if a patient is overdue for an office visit or a lab check, the patient would likely receive a courtesy refill, and then there would be a scheduling action that would be taken to make sure that that patient is seen to get whatever corrective action needs to be taken completed. And so you see here, this medication was recommended to be refilled for 1 month based upon the protocol, but there was an additional scheduling action that was taken. So there's an office visit request or an office visit scheduling action that was in this case sent to the CMA. And so then when you look at the CMA's request, they would see that the hemoglobin A1C as well as an office visit needed to be ordered for this particular patient. All of this was teed up in the request. So all they need to do is sign off on that. Again, the goal is to allow in this case, the MA to sign off on the ordering of those ordering of those labs. And then they would follow the usual workflow as far as bringing those patients back in, whether that's sending a letter, sending a patient portal message, or calling the patient. So that's on the scheduling side. And then on the physician in-basket side, so this is there's going to be about 20% of refill requests that can't be handled via protocol. So these are for medications such as the controlled substances, antibiotics, antifungals, those sorts of things. that need to be addressed by the physicians directly. And so those don't get delegated, but those automatically get sent to the physician with all the information that they need to make an appropriate decision. And so you see here with this particular medication, Swoop went in and identified the last qualifying visit, the next scheduled visit, when the medication was started, and when the medication was last refilled. And so again, the goal is for that these medications that need to be addressed by the physician, that the physician has all the information that they need to make a quick decision on that particular request. And so I'll again pause and see if there are any questions that need to, or that are applicable based on seeing some more examples. And then I'm going to jump into show some case studies.
Yeah, I think that's a good time because I had a question around efficiency and productivity gains, particularly around ROI. We're generally around ROI, so I think this is actually a great transition.
Excellent. So as I mentioned, so a number of organizations are going to engage with us for different reasons. The first is where the physicians are doing all this work, and so it's great from the physician side because the physicians come in and are seeing before 15 or so refill requests per day, and then we come in and put the application and the associated workflow in place, and they're seeing that go from 15 to 4 requests per day. So the physicians are thrilled, but the question is, from the staff side, how much of a burden does that place? And so to give you an example, these are all some of our customers. So some of these customers are certainly based in California, but then others are spread across the country as well. And to show you a case study from one of these customers, which is Health Partners. So Health Partners is an Epic organization that's based in Minneapolis. And they had done what I had just previously mentioned. So they had taken the work of the physicians. So they were a large organization, so they had around 250 primary care physicians, and they centralized all this work amongst RNs. And the reason that they did that was because with all the work that was being asked of the staff, they needed to free up the clinic staff time to focus more on their population health efforts. And so they centralized this team, but the challenge was that they needed 13 RNs to handle refill requests for those 265 providers. And so there were 13 nurses on a daily basis that were working the inbox, and they were comparing refill requests that were coming in against their standard manual protocol. And so what those nurses would be doing is they would see the refill request, they'd look at the protocol, they would go into the EMR, they'd pull out the relevant pieces of information, such as when the patient was last seen, when they had last lab work done, then they'd compile that, they'd document it, they'd sign off on it. And so it wouldn't need the physician's involvement, but it would, through that process, it would take usually on average 5 minutes or so per request. And so the nurses on average were able to process 120 refill requests per day. And so that was their expected efficiency over an 8-hour period. But they were processing on the order of 1,500 refill requests per day. And so you can see where that mismatch was. And so then what happened, or what suffered as a result of that, was the patient turnaround time. So as many of you may or may not know, the magic number for refill requests is getting them completed within 24 hours, because if you do that, then the pharmacies will substantially reduce the duplicates that are sent over because they're getting quick responses on the original request. But their turnaround time was fluctuating between 24 to 72 hours on average. And so that then cost them as an organization close to $2 million in terms of fully loaded staff costs to achieve this. So it was a substantial cost for this organization to implement it. But this was all before the application, before introducing Swoop. Now, after Swoop, they were able to reassign 9.5 FTEs that were then brought to more top-of-license work for them. So they were able to then transition those folks to working on Coumadin, which is where they had a shortfall within their organization. And so the way that we were able to do that is we were able to take the average refills that were processed per RN from 120 to 350 plus, and the plus is because that a number of the requests were either automatically handled, so such as things like duplicate requests, or were automatically routed to more appropriate members of the team. And so through that process, they were able to get substantially more efficient at the refill process, and on a regular basis, they're now zeroing out that inbox. So usually it would be a great day for them to end the day with 2,000 refill requests sitting in their inbox, and now they're regularly zeroing it out. And so after implementing the technology, they were able to go from just under $2 million in terms of cost to the organization to right around $500,000 to total cost to the organization to handle prescription refill requests. And additionally, on top of that, they've since added 90 additional providers to the service. So now they're supporting 375 providers with only 3.5 FTEs using the Swoop technology. And are there, as I go over that, any questions that as you hear this, or any comments or questions about your organization, or any folks that are thinking about making a transition towards centralization, or any folks that are thinking about standardization or delegation in any form? Or are there any other questions as you've been hearing the presentation?
So we'll give people a few, maybe a minute to type in questions if there are any, but meanwhile, I received a question that actually is relating to a question that came up earlier, which is around the technical integration. It's around the EHR piece. Someone has sent in the question asking, if we don't use Epic or Allscripts, does that mean that we cannot use this application?
Yeah, so as of today, we don't support any other EMRs, but if you certainly pass along the EMR that you are currently using to Jared, and so we can keep track of this, because as we're looking to expand as a company, we're looking at EMRs that we're going to be supporting in the future. And so I'd love to hear from the folks on the phone if this would be potentially of interest, what EMR you are currently using, and then we will be doing our best to support those in the future. But as of this moment, yes, there's only Allscripts and Epic support today.
And that EMR is actually a next-gen EMR.
Excellent. Okay. Yes, thank you for that that data point. And if there are any others on the phone, please pass that along to Jared so that we can get an idea of their representation on the phone. And are there any other questions?
You know, John,
then I'm going to...
Yeah, what did you have next? Because we could open up the lines, or we could go over and go on to the next.
Yeah, so I'll keep going on. So so that was just the first area that I had talked about, which is prescription refill requests. So as an organization, we're quickly making the transition into many new areas that are going to be very similar to prescription refill requests, meaning that they usually are either taking up substantial tasks that are taking up substantial physician or staff resources today, and we're going to be using a similar methodology to take that work off of the physicians and staff's plate. So I'll touch on these briefly, and so these are, so the first one is around Tune, which is serum level tracking with a focus today around INR management. So in much the same way, I'm sure many of you on the phone are familiar with the workflow, that the Coumadin needs regular INRs to be performed to assess the patient's the thickness of their blood, but this regular monitoring of INRs requires substantial staff resources to manage it. So usually this process is contained within a Coumadin clinic, and then the organization is either using a separate, or is using their EMR or using a separate application to manage these particular patients. But the goal of Tune, in just the same way that we've done with refill requests, is to apply a layer of automation and protocols on top of a previously manual process. So what is very common today is that an INR gets received, they get then run through protocol, which will then either adjust the dose if the patient is out of range, will increase or decrease the dose that that particular patient needs to be on, as well as then set a follow-up INR date. And so through this same exact process that I've outlined before, we will then put in place protocols that will allow a substantial decrease in the amount of staff resources that are going to be necessary to manage patients on Coumadin. The second new application area is around diagnostic results. And so again, the same idea here as refill requests is that physicians on average will see 20 patients per day, will have at least 15 labs drawn for those particular patients. And then a day or two after, the physicians and our staff are tasked with dealing with the lab results. So that includes building those action plans, communicating them to the patient, documenting them, and storing them within the EMR. And so the goal of this particular application is to, again, put in place a layer of automation protocols on top of it that will automate things like normal requests. So normal requests will be automatically released to the patient, which is something that many of you might be utilizing today, but then also with an explanation to the patient around their results. So the same type of process that would happen today, but gets applied automatically with the application of the technology. But then putting in place from there layers of delegation where we could, for example, put in place a protocol around starting or adjusting the dose of a statin based upon the results of a lipid panel. And so the goal of this application, again, is to remove work from the physicians and get everyone working to the top of their license. And the third area is Scout, which is focused on pre-visit planning. And so the goal of Scout is to as much as possible, use data from the electronic medical record that can give us an idea of those usually diagnostics, but also would be other things, including immunizations, vaccines, that would need to get performed for that patient ahead of the patient's visit. So it's the proactive version of what I just talked about for diagnostic results, but instead to put in place protocols to get the patient in, to get labs drawn a day or two ahead of an office visit, or maybe a couple hours ahead of the office visit, so that the physician has all the information that they need at the time of the patient visit to make a decision, rather than having those results pile up in their inbox a day or two after the patient visit. So the goal of the application is as much as possible to drive toward the proactive world of management moving forward. And so for all three of those, these are applications that we're working with development partners on. So if there are any organizations on the phone that would be interested in participating with us in that program, I would be happy to pass along some additional information to give you an idea of, one, how the application, how we're currently thinking about the application, as well as how you might be able to engage with us moving forward in the application development process. And so ultimately now, again, what we've built up is this suite of care redesign applications. So applications that are focused on getting everyone working to the top of their license. And so when we go back to that particular patient, we think now, instead of being reactive about that process as we were at the beginning, to instead think proactively. And so, as I mentioned, everything, rather than getting done at seemingly random times between patient office visits, instead, the goal of our applications is to do as much of this as possible upfront in a proactive fashion around the patient visit. And so then what happens is, as I just mentioned, talked about the pre-visit application, the goal is to identify that the patient has an annual exam and trigger orders based on protocols. Then bring that patient in with the annual exam where they've already had medications on all orders run through protocols and ready for approval. So then we can ultimately get ahead of things like asthma rechecks and INR redraws to make sure that, again, we're getting proactive with our patients rather than being reactive. And thank you for everyone on the phone today. Thank you very much for your time and attention. And now we can go ahead and open it up if there were anyone on the line that has any questions.
Canel, if you don't mind, please open up the lines. And meanwhile, I actually have a question around Tune, actually, and if there's any development work being done for other protocolizable conditions such as ATN and DM.
Sorry, what were those? What were those two that were mentioned?
HTN and DM.
Got it. So not as of this point, but that's exactly the direction that we're going as a company, is to focus around these conditions that we can protocolize in the same fashion. And so if there's interest in your organization, so if you guys are thinking about protocolizing these workflows today, or you already have manual workflows and you're looking to get more efficient, I believe that Jared's going to give you some mechanism to reach out after this webinar. And I'd urge you to do so, and I'd love to spend some time talking with you to understand what you're trying to do and what you're ultimately looking to accomplish, and see how we might be helpful for you.
Yes, certainly. So Jonathan, I will connect David with you after this webinar.
Excellent.
So I believe the lines should be unmuted. So if anyone has any questions, please go ahead and speak up. Okay, well, as Jonathan mentioned, HealthFinch is, always looking for ways to work with and engage with the safety net providers here, especially in California. So whether that be through Swoop or one of the other development work areas. And so, CHCF, along with HealthFinch, is always, ready to sort of kind of push it to that area. And we're always looking for feedback too, right? And so, in any case, I would love to hear your thoughts and interests on any of those topics that we talked about today, and whether that's right now on the line or afterwards over a sort of a follow-up call. Happy to do any of that. So let me know if we don't have any more questions. I'll wait maybe for another 15 to 30 seconds. Oh, I think I hear some noise. Is that you, Kenneth?
Yes. So my name is Kenneth. I work for a federal qualified health center in San Francisco. Our EHR system is next gen, and we actually have internal pharmacies. They use QS1. My question was that on that slide, Jonathan, you mentioned about it potentially provider deleted the medication, how the pharmacies will be able to have a two-way communication in terms of confirming that. Was that what you said this Swoop can do?
No, so what the application does is it points out that there is a discrepancy. So as that refill request was received, it would identify that the app or that med was previously discontinued. And then what we're putting in place and what that slide was meant to communicate was that there would be a standard workflow that we would work with your organization to put in place with your staff to alleviate that discrepancy. And so what that workflow would look like is usually doing some additional digging into the EMR to identify if that med was truly discontinued, and then if not, putting in place a workflow where the staff would call the patient and request or ask the patient if they were still on that medication or not, And then if they were and the patient was actively requesting the med, then it would get forwarded on to the physician for final approval. But it's not, so Swoop does not handle the communication between the physician and pharmacy, like SureScripts would today.
Right. I see. Okay, I got it. And there's no estimated plan about possibly opening up to next-gen users?
So we're actively looking at a number of EMRs, but we don't have a current ETA on that as of this point.
I see. And I don't know if that's, you didn't talk about the cost. What typically would cost? Is it based on a FTE kind of provider kind of cost, or?
Yeah, so it depends on the size of the organization and the EMR that we would be working with, because it's two very different models depending, but it is on a per physician basis, and it also depends upon the size of the organization as well. But one of the things that we're fortunate enough to working with the California Healthcare Foundation is that we have some flexibility in terms of how we come up with pricing. So for folks that would be of interest, I'd certainly urge you to reach out to me or to the folks at the California Healthcare Foundation, and we can set up an additional discussion, and I can give you a much more concrete number of what that cost might be.
Great. Thank you so much.
Thank you very much for the question.
So everyone has had a chance to take a look and maybe jot down Jonathan's contact information if you want to reach out directly to him. If there's anything that you'd like to discuss with me first, I am going to throw up a slide here with my contact information, and happy to have a follow-up conversation with you. So Jonathan, if you don't mind, I'm going to move the ball over and share my screen. Give me a second here. Once again, I'm Jared, and my email address is up on the screen. It's jpeo@chcf.org. All right, well, once again, thank you everyone for joining us today. I think this will conclude our webinar, and also thank you to Jonathan and HealthFinch for presenting today.
Absolutely. Thank you for having us.
Take care. Bye.
Bye-bye.